A rhinoplasty or nose job, the simpler terms, can be performed in two different ways. There's the open technique and the closed technique. And it really depends on what we're doing between the two different types of procedures. If I'm going to perform a lot of tip work or a hard twisted nose, or usually revision surgery, I'm going to perform an open procedure. And what that really entails is making a little incision here at the columella, which by the way heals beautifully. Then I make the incisions inside the nose, and I'm lifting up the skin so I can look at everything. So I have full exposure. And what that allows me to do is really work on everything from the upper part of the nose, the middle, the lower part of the nose, and see exactly what I'm doing. If I'm also working on a very hard deviated septum, or if there's a hole in the septum called the septal perforation, the open approach is really the key. Now recently I've been trying to perform more closed operations with doing a good amount of tip work. And a closed rhinoplasty is where the incisions are made entirely inside the nose. There's no incision outside here, everything inside. Now the advantage of that is that the swelling is less. The open procedure is better exposure and the incision heals beautifully, but there's more swelling, which it all subsides, but it takes longer to heal from the swelling. The closed rhinoplasty with the incisions inside the nose causes, the closed rhinoplasty has less swelling. And the only limiting factor with that is you don't have as much exposure. But as I mentioned, that's one of the areas we're trying to do is go back to doing a little bit more closed rhinoplasties. Right now, I would say that 75% of my rhinoplasties are open, 25% closed. In addition, when we talk about how do you do a rhinoplasty or a nose job, well, the way you have to look at it, the nose is divided into three areas. The nose is divided into three areas. This is the upper dorsum right here, made out of bone. The middle part of the nose, the middle vault, made out of cartilage, and then the tip in the nostrils. And with the upper part of the nose, it depends on what we're trying to do. If we're trying to augment it, to make it taller, especially in ethnic rhinoplasties, we're going to be adding cartilage. We might be bringing the nasal bones in when we're taking a hump down. It depends on what we're doing in that area, but you have to work on the bone. Make it bigger, smaller, more narrow, make it wider. The middle part of the nose, called the middle vault, usually you can have a hump here. So when you have a hump in this area, you're going to shave off the cartilage. Now, in that same situation, there might be already too much taken off from before, from a previous surgery. So either we might want to augment that area, and if there's a sunken area in the middle vault, it's called a saddle nose deformity. In addition, if someone has had a previously aggressive septoplasty, by the way, a septoplasty is where the partition in between the nostrils that divides the left side and the right side, called a deviated septum, where we repair that by removing some cartilage and bone to make the airways straight on the inside. Sometimes when the septum is very deviated, going one way or the other, it could be due to a deviated septum. I'm going to say that again. Sometimes a deviated septum can cause the tip to deviate. So if the tip is deviated to the left, sometimes the septum will be deviated to the left. If you correct the deviated septum, the tip should return back to midline. So in these situations with the middle part of the nose, after we take down a hump, we sometimes have to put little pieces of cartilage in here called spreader grafts. What those will do will prevent the middle part of the nose from collapsing in. If that happens, it's called an inverted V deformity. So what I'm saying when I'm performing middle vault and then tip surgery, my goal is to make the nose smaller, but at the same point, I have to make it stronger so that it won't collapse. The more destructive or the more removal of cartilage we do with the nose, the more the forces are to make the nose contract, pinch, over-rotate. So my goal is to make it smaller, but again, stronger, so that it won't have these things happen. Essentially, that's how we perform a rhinoplasty. A lot of times we're going to need cartilage for the nose. When we need cartilage for the nose, if there's not enough inside the septum, or it's been removed previously from another surgery, sometimes we'll go to the ear, sometimes we go to the rib. The great thing about using rib is the procedure. The great thing about using rib, it's abundant cartilage. There's also tissue over the cartilage called perichondrium that we can use. And the incision's hidden in your inframammary crease, is just below your breast or your chest in a male. And the cartilage is firm and straight. So my first source is septum, my second would be rib, especially if I need a lot of cartilage. Then my third would be ear. For the ear, we make a small incision behind the ear. I take some of the cartilage out from right inside this area. The incision heals beautifully behind the ear, and the ear just comes back just a little bit. So septal cartilage is another way to go. It's great for camouflage, but it does not add great support. And depending on how long these procedures take, I take my time with rhinoplasties. My average rhinoplasty can be anywhere between 3 and 5 hours, depending on what I'm doing. If I'm doing a big revision with rib, and I'm taking tissue from the scalp called temporalis fascia, and I'm doing a third or fourth rhinoplasty, the whole procedure can take 7 or 8 hours. The reason why it takes that long is we're taking our time to make sure that every little part of the nose is as perfect as it can be in surgery. The negative thing about all this is the healing. Sometimes the three-dimensional healing and the shrink-wrappage of the nasal skin makes healing not predictable. And that's why you have to give your nose a full 2 years to heal.